Another series of disorders we can talk about is include dissociative disorders. So these are a particular category where we see that this is extreme and frequent disruptions of awareness, disruptions of memory, and identity. And this is going to impair the person because they don't know who they are. Now, this is really important to note that the dissociative disorders are not schizophrenia. Okay? When we talk about dissociation and a dissociative experience, we're talking about a break or disruption in consciousness. We're seeing that awareness, memory, personality, and identity all become sort of separated or divided. So it's important to note that there are three basic disorders that are involved or categorized in these dissociative disorders. So dissociating is sort of this break from reality. So the dissociative disorders that we're going to talk about, I'm going to talk about one sort of separately, is we have dissociative amnesia, dissociative fugue, and dissociative identity disorder. And we're going to talk about the dissociative identity disorder on the next slide. So dissociative amnesia is when a person has a partial or total inability to recall important information, and there's no medical condition to explain why. The person didn't get hit on the head, they didn't experience any trauma, physical trauma, nothing to explain why the person has this sort of dissociative amnesia. This is kind of like on a soap opera, the person just sort of wakes up and has no idea who they are. And so we find that the person tends to develop amnesia for personal events and personal information rather than general knowledge or skills. They may know who the president is, they may know how to do things, but they don't know who they are. Now, dissociative fugue is kind of scary because this is a sort of a sudden and inexplicable event where a person's traveling far from home. They may wander to another city, wander to another country, and they don't have any recollection of doing that. They don't know who they are. And they sort of wake up somewhere else and go, what am I doing in Italy? Last time I remember I was in Wise, Virginia. And so this can kind of go in hand with amnesia. And of course, soap operas love to kind of jump on this sort of bandwagon, and a person might find themselves in another city not knowing who they are, and then they, start a new family and then sort of realize who they are again. So that's kind of more of a fantastical sort of version of it, but that would be, and these are rarer conditions. That would be something that we would see in like a soap opera. Now, dissociative identity disorder, this is also referred to as multiple personality disorder. This is not schizophrenia, okay? Now, dissociative identity disorder, DID, is like having multiple identities, whereas schizophrenia is like having one identity that's shattered. Dissociative identity disorder is having multiple identities. So at least two or more distinct personalities, distinct identities, and the person can have very extensive memory disruptions. They can have different ages, male, female identities. It doesn't seem to follow any particular pattern. Now, the interesting thing is that each identity, so a person can have 2, they can have 14, right? They can have any sort of range as long as it's obviously more than 2. Each personality has its own name, may have its own experience, as if it's got its own personal history and personal self-image. And we call these alternate personalities alters. Now, what's interesting about dissociative identity disorder is that there are some medical health professionals that are not necessarily convinced that it's a genuine psychological disorder. Now, in my personal opinion, I do think there are some very rare cases where this does happen, but it could certainly be cases where the person is faking it. And really, there's no way to know for sure. But I do think it is rooted in actual disorder, And then we see more cases probably because people are learning how to act that way. And so there was a really dramatic increase in diagnosed cases since the 1970s. But interestingly, in the early 1970s, there were several books, films, and television dramas about multiple personality disorder. They became very popular. And so some patients may have actually learned how to behave like a person with multiple personality disorders. And so this is just something that is where a lot of mental health professionals believe that there may be legitimate cases, but there are certainly people who claim to have this who are just acting. And some ways, some causes or theories to explain what dissociative identity disorder is and how it forms. Now, some people argue that it's an extreme form of dissociative coping. So if a person's gone through an extreme physical or sexual abuse or trauma during childhood, it's a lot of people, a very high percentage of people do report having experienced some sort of childhood trauma at some point in their lives. And one of the theories is that the child dissociates from their identity to protect themselves and creates these alternate personalities to experience the trauma for them. The problem is that we tend to see the opposite effect happening to trauma victims, where they tend to be even more in tune to themselves and less likely to dissociate. And it's this sort of dissociative coping theory is extremely difficult to test. This is really something that is hard to actually quantify and test. And so that's why it's such a difficult disorder to know if the person's actually experiencing it and what actually causes it. Now, so dissociative identity disorder or multiple personality disorder is not schizophrenia. So let's talk about what schizophrenia is. So schizophrenia comes from the Greek meaning split in mind. So split refers to the loss of touch with reality. This is where a person is experiencing very severely distorted beliefs, distorted perceptions, and thought processes. It tends to be diagnosed when 2 or more of the characteristic symptoms are present for at least a month or longer, and people will go through episodes where they actually experience specific symptoms. Now, I want you to think for a minute about experiencing something that you feel is a part of your reality. And so what I'd like for you to do is just kind of do a little exercise. And I want you to look around anything that's around you. So if you have a pencil or your phone or your tablet or a computer or something, and I just want you to touch it. I want you to pick it up and I want you to kind of feel it. I want you to feel the weight of it. Is it cold? Is it warm? Is it hard? Is it soft? Like, what is it that you're experiencing? I want you to even smell it. I want you to, really, experience the item that's in your hand. And then imagine that someone tells you that it's not there. Now, at first you're going to say, well, that's dumb. I feel it. I hear it. I smell it. I can shake it. I can bounce it off something. I can experience it with all of my senses. You can even lick it and taste it, right? And a person says to you, well, no, you're not holding anything. Now, at first you're going to think that the person's messing with you. And then if you ask, then you're probably going to say, well, I'm going to go ask someone else. So you might ask another friend, somebody you trust, that will tell you the right answer. And if the person says, no, you really don't have anything in your hand, now you're going to start feeling kind of, like this is weird. That doesn't make any sense. And then if you continue to be told that what you're experiencing is not real, what you're holding or feeling is not real, then you're going to really start to question your reality. Now, you might hear someone's voice. Is that real? You might see somebody in the room. Is that real? Even though you can touch them, even though you can hear them, even though you can see them, you start questioning every element of your reality and you don't know what is quote unquote real and what isn't. And so it can be very scary to experience schizophrenia, especially when you're experiencing a psychotic break, because you have no idea what's actually happening. When we look at some of the symptoms that a person might have, the positive symptoms, and remember, positive in psychology and negative in psychology have different meanings. So positive means the presence of something that shouldn't be there. Negative means the absence of something that should be there. So positive symptoms would be something like delusions or false beliefs, thinking that that you're the president, thinking that somebody's after you, being paranoid. This can lead to really dangerous behaviors, because let's say you have a delusion that someone's chasing you, or a delusion that someone's after you, and you may want to get away from them. So you jump out of a window, and that might be a window that's really high off the ground, and you could end up, harming yourself or killing yourself. Having a hallucination, which is a false perception. These are indistinguishable from reality. This is the thing in front of you. You can smell it, you can taste it, you can hear it. Some people experience hallucinations or disruptions in their senses where they feel things crawling on them. They may say, there's ants all over me, or there's bugs on me, there's spiders on me. And they look down, they can hear them, they can smell them, they can feel them all over their body, and you say, there's nothing there. And that's very frustrating for a person that's what they're experiencing in terms of their reality. We also see addition of disorganization. So it might be disorganized thoughts, disorganized speech, they don't make sense, disorganized behavior. And this is all things that are present that really should not be there. So we can see also negative symptoms. So these are symptoms that are deficits or decreases that you should expect, that you shouldn't expect to see in a person. So they may have decreases in behavioral functioning, decreases in emotional functioning, and they can occur in combination with positive symptoms and in combination with each other. And they tend to vary across cultures, what's considered sort of typical and acceptable in each culture. So flat affect is just in a flattening of emotion, a lack of experiencing emotion. So if you say to somebody, your dog died, and it was like their dog of 12 years, they may not react at all. Or if you tell them something really happy, really great news, they don't really react. They've kind of have a lack of emotion. Alogia is the lack of speech. So you might see the person not talking at all. You might see that they have very reduced production of speech. They may only say, sort of parrot things back to you, or they may not speak at all. Avolition is lack of motivation. Now, a lot of people think, oh, well, this isn't too bad. But this is very severe. This is referring to the inability to initiate or persist in even simple forms of goal-directed behavior. So we're talking about lack of motivation to eat, lack of motivation to go to the bathroom, to literally go to a toilet and go to the bathroom. So they might pee on themselves, or they might, they might poop their pants because they just have zero motivation to get up and go to the bathroom. They may lose motivation to leave the bed. They may fall into a pool and not even have the motivation to swim up to the surface. This is a severe lack of motivation. There is a YouTube video here that covers 4 different patients with schizophrenia. All of these cover some of the different symptoms that we've talked about here. I do want to warn you, sometimes these are a little bit difficult to watch, and there is at least one patient who uses very, very serious language, adult language. So, I do want to caution you that, and if you're in a place where you can't listen to, if you're at work or something that you don't want to listen or watch a video, I would suggest doing that when you are in a place where you can watch it sort of privately. Now, when we look at the types of symptoms and the amount of symptoms, we see that auditory hallucinations tend to sort of take it in terms of how the percentage of hallucinations that a person is experiencing. So that's 63% experiencing some sort of auditory hallucinations. You might be hearing voices or hearing things that are not there. 27% are visual, might see a person, might see a thing, might see something really scary. 15% are tactile, and so they might feel something on them. They might feel like something's crawling on them. And 11% are smell or taste. So they may be eating their food and then suddenly they go, oh my goodness, someone's trying to poison me. And they might actually taste something that's off. Taste something that to them is not, that is poisonous. And they might smell gas and say somebody's trying to poison me. Someone's trying to kill me. Someone's trying to, harm me. And so this can be really scary for a person to experience. So what's going on in the brain when a person is experiencing a hallucination? So what's really interesting, and these are PET scans, where we can kind of see what's going on during the course of an actual hallucination that a person with schizophrenia is experiencing. So this right here is activation that is shown when a person with schizophrenia is in a PET scanner and they're hallucinating disembodied heads yelling orders at them. So we see temporal lobe activation, which will say, hey, this is auditory. The person is actually physically hearing something. This is exactly what you would expect if somebody is listening to something. This is auditory temporal lobe activation. We see here that the occipital lobe is activating. This is exactly what you would see if a person's seeing something right in front of them. And so this person's brain is telling them that something is in front of them, that they're experiencing something going on. Now, what you don't see is also important. What you don't see is frontal lobe activation. Now, your frontal lobe's job is to tell you what is real, what is not, and what you should pay attention to. And if we don't see any activation in the frontal lobe, that's telling us that the brain is not operating correctly. And it is not doing its job to say, hey, what you're hearing and what you're seeing is actually not real. This is the decision-making part of the brain. This is the part of the brain that's really in touch with reality. And so this could explain why that a person is actually experiencing these hallucinations is because the right coordination of activity in the brain is not happening. Now, if we look at the kind of percentage of symptoms, positive versus negative, you can see here that delusions make up a very big chunk of the positive symptoms, 81%, with hallucinations about 58%, and 22% only being disorganized thought. When looking at negative symptoms, avolition, that lack of motivation, the apathy, really takes the cake here for negative symptoms, 85%, with flat affect being 65%, poverty of speech, which is lack of speech or severely reduced speech being about 30%. So about 200,000 cases are diagnosed each year in the United States. And about 1 million Americans are treated annually. So this makes up to be about 1% of the population. And this is 1% of the population experiencing at least one episode during their life. And this is related to and correspondent to most cultures. So it doesn't seem to be anything specific to Americans. This is something that seems to have a correspondence rate that kind of matches across all cultures. Now, what's really interesting here is that the onset of schizophrenia typically occurs after puberty. We're seeing, anywhere between 14 to 20 years old, where the person might demonstrate their first psychotic break or their first series of symptoms. But what's interesting here is that if you look back at the behavior of a person who's later diagnosed with schizophrenia, you can actually see some red flags during childhood. They might behave differently or oddly. They may, kind of demonstrate something that parents go back and go, yeah, that was odd. And so it's usually not enough to warrant a diagnosis or any sort of trip to the doctor or anything like that. But we can see signs prior to young adulthood that would point to a person potentially being able to recognize that they have schizophrenia. Now, when we look at about what the course of development for the disorder, about a quarter of those who experience one episode of schizophrenia recover completely. Okay. So a quarter of people who experience just one episode tend to recover completely and no longer have any problems in the rest of their life. Okay. Another quarter who experience recurrent episodes are functional. So they have minimal impairment and they are able to, for example, keep a job. They're able to, maybe with maintenance or medication or treatment, continue on with their life. So if we look at this and looking kind of like, a graph here, a quarter of them we're experiencing complete recovery. Okay. Complete recovery. Another quarter looking at minimal impairment, okay, but functional. Now half, this right here, half for people who are diagnosed with schizophrenia, this is a chronic mental illness. Their ability to function is likely severely impaired. They may be doing treatments for the rest of their lives. They may not be able to ever hold down a job. They may have a lot of issues in their lives. So about half of the people who are diagnosed with schizophrenia end up it being a chronic condition that they're really struggling with for the rest of their life. Now, why do people have schizophrenia? It turns out that there are definitely some genetic factors. There's schizophrenia is associated with thousands of common gene variations. It turns out that bipolar disorder and schizophrenia might share some of the same genetic origins, but again, because there's so many gene variations and there's some overlap, it's really difficult to differentiate and know for sure. About 50% of identical twins who have schizophrenia are going to develop it. So it's a 50% risk rate for a person who has an identical twin with schizophrenia. But we do know that there are environmental factors that play into here. And so we know that in family studies and twin and adoption studies, it does tend to have a genetic factor, tends to cluster in certain families. And the more closely a person is related to that person who has schizophrenia, the greater the risk that the person may develop schizophrenia. So for example, if it's a cousin or a great uncle versus a sibling or a mom or dad, the mom or dad or sibling relationship is much closer, and we're going to see that person is going to have a much higher chance of having schizophrenia. There could be some chromosomal locations that are associated with genes that could influence brain development, and associated with that is memory and cognition. There seems to be some relation there, but we don't know exactly what the chromosomal locations are. We don't know exactly what the gene variations are, but we do know that there is some genetic factors involved here. Paternal age is actually much more important than maternal age. So, a mother's age can impact chromosomes. Like, for example, the older the mother is, once you hit 40, the risk of having a child with Down syndrome increases exponentially. But with schizophrenia, it turns out that mother's age doesn't really have much of an impact, but the father's age does. So it could be that schizophrenia might be caused by mutations in the sperm of fathers, because as the age of the father increases, we see, of course, the increased rate of mutation. So the schizophrenia rate, compared with people who with people who have fathers younger than 25 years, it turns out that the fathers who are between 45 to 49 years old are actually twice as likely to have a child with schizophrenia. And if the father is 50 years or older, the rate is actually 3 times as likely for a child to be born with schizophrenia. Another potential explanation is the immune system viral infection theory. Women who are exposed to the flu virus during the first trimester have a 7-fold increased risk of a child who may later develop schizophrenia. And mothers who were exposed to the flu virus during the first or second trimester show an increased rate of a child developing schizophrenia. And it turns out that schizophrenia occurs more often in those who are born in the winter and spring months. This is where upper respiratory infections tend to be more common. And so the idea is that there's some virus, maybe the flu virus, that if the mother contracts, the fetus may be impacted by that. Now, we do know that there are some brain structure differences in people with schizophrenia versus people who don't. About 50% of people with schizophrenia show some type of brain structure abnormality, so about half of them. The most consistent finding is that their ventricles, so this is what stores the cerebral spinal fluid, is enlarged. They also have less gray matter tissue and less overall volume of their brain tissue than compared to somebody who does not have schizophrenia. However, we don't know if schizophrenia causes these brain abnormalities or if the brain or abnormalities are causing schizophrenia. These are all completely correlational. We don't know for sure if this is actually what's actually causing what. If there's a third factor that's causing all the above. And finally, looking at psychological factors, if a person is genetically predisposed to develop schizophrenia, they're going to be more vulnerable. And if the person is in a disturbed family environment, that could sort of spell disaster for the child. And so, a person might have a genetic predisposition, but if they're in an environment where it isn't fostered and the genetic variations aren't sort of switched on, then that person likely isn't going to develop schizophrenia. Whereas if a person has a genetic predisposition and then they're placed into an unhealthy family environment, that could lead to potentially the child having schizophrenia. But again, it would have to be a combination of factors, and just because you're in an unhealthy family environment doesn't mean you're going to develop schizophrenia. The last slide I have here is just a review slide for you to kind of organize for your studying. Please make sure that if you have any questions that you